Good evening, everyone. Today we are starting a sessions of OSCEs. As you know, it is mandatory that these cases will come as a part of CCS in EDIC as well as IDCCM exams. IDCCM exams pattern keeps changing. Sometimes it's a long case, sometimes it's an OSCE, sometimes it can be at the bedside. Basically this practice is to help in the IDCCM preparation as well as for EDIC part 2. Okay. Today I have my colleague Dr. Soumya with us. She is also preparing for EDIC exams. You're able to hear me?
Yes, sir.
One minute. No?
Yeah.
Hello? Can you hear me now?
Hello.
Yes, Rajvardhan. Please continue.
Okay, fine. Sorry. Some confusion. Okay. First, we are starting with the neuro sessions. So here is a 65-year-old male patient presents with sudden onset dizziness, difficulty walking and vomiting. On examination, it revealed that patient has a horizontal nystagmus, left-sided limb ataxia and gait instability for last 3 hours. Patient arrived ED in unresponsive state. GCS was E1, V2, M4, and also noted to have some involuntary micturition at this point of time. Initial assessment of vitals is heart rate 112, BP of 150 by 100, respiratory rate of 20 breaths per minute, saturation 92% on room air, temperature of 98.4 and GI-BS of 317. Neurological examination, patient was drowsy, GCS of E1, V2, M4, pupils bilateral equivalent reactive. CVS of S1, S2 present. Chest is clear, abdomen is soft, non-tender. So now, generally, once they give this slide, there will be some time for you people to uh, practice what exactly is the case. Generally, you'll get an idea what is the case, but there are a lot of, once you have that vignette with you, there'll be a lot of questions will be asked related to that vignette, example, diagnosis, approach and all. But I'm not giving you so much time here just because it's just a practice session so that you can learn it fast. My maximum 1 minute I'll give you. Then we'll go. You just see this case and guess what it is. In the meantime, I'll start asking questions after 1 minute. We'll start at 7:09 now. Dr. Soumya, you are ready, right?
Yes, sir.
It's always better to take down the points in the exam. Exactly what is the case, what is the expected answers we're supposed to, roughly already what are questions they'll ask. Because time is very essential in EDIC part 2, because you spend a lot of time in telling the same points again and again, it'll lose time and you'll not be able to answer most of the questions because of that. So now, Dr. Soumya?
Yes, sir.
Okay. Your first question is, what are your differentials in this case?
My differentials would be, first thing would be stroke.
Okay.
Second would be some alcohol intoxication or
Okay.
intoxication. Third would be any infections
Okay.
or a drug overdose or
Okay.
metabolic encephalopathy, more so some a decay, because I saw that there was a hyperglycemia on the investigations.
You're right about stroke. You think which area stroke it might be?
So because it is ataxia and dizziness So it fitting more into a cerebellar stroke.
Yeah. Cerebellar
Posterior
posterior circulation.
posterior circulation stroke. Yes, sir.
Always it's better to mention when you mention stroke, it's better whether it's ischemic stroke or hemorrhagic stroke.
Okay. Ischemic stroke.
Okay,
Yes.
it can be both. You
Both.
don't know
Yes.
actually with
Yes.
that issue,
Yes.
it's very difficult to say. You'll
Okay.
mention it's a posterior circulation stroke, it can be hemorrhagic and ischemic. As
Okay.
you know, this a lot of cerebellar signs are there. You can work with other differentials also, as you told correctly. There's
Yes.
always alcohol intoxication or metabolic cause. It's the first one of the most important differential.
Yes.
Intracranial space accumulation, unlikely in this case because they're quite acute. But
Okay.
what happens in the exam now, there will have few differentials which will carry marks. Example, this posterior circulation stroke as well as bleed. It will carry the two important marks, but there will be mass distribution for others also because I told that there is involuntary micturition. Seizures is a possibility. As you told, DK is also a possibility. Alcohol intoxication. These are the differentials. Okay.
Okay.
So, as you know, next, any patient come with a stroke, what are the stroke mimics you want to rule out?
Mostly my metabolic causes like hypoglycemia. Second, any hyponatremia.
Okay.
Third, like drug intoxications, alcohol overdose.
Yes.
Then
Any condition which can present with hemiplegia or something like that? Mimic hemiplegia. Migraine is important. Okay.
yes, yes.
As you told already, migraine, seizures,
Okay.
hypoglycemia, intoxication. These are
Okay.
your differentials. Okay.
Yes.
So this is which imaging you would like to consider? Sorry for that. Which imaging you would like to consider in this patient?
Uh, I mean, it depends on when has the patient arrived. If he's
Okay.
in a window period, but however, because it is looking like a posterior circulation stroke, I would rather consider MRI brain instead of doing a CT brain because the question of thrombolysis here is less likely. So I would go ahead with MRI brain.
Why thrombolysis is less likely?
Uh,
3 hours, right?
Yes, sir. Actually, mostly the anterior circulation strokes fared better with thrombolysis, unless.
No, there's nothing like that. In fact,
Okay.
posterior circulation score also fare better. In fact,
Mm.
they say that you can extend generally what is the time duration we stick for thrombolysis?
4.5 hours,
Yes.
or
You can
we can
extend further
better.
for posterior circulation stroke. Okay.
Yes. Okay. So,
So,
if we are considering thrombolysis, then I would like to
no,
do
wait.
non-contrast.
Okay. You did
Okay.
an MRI of this patient.
Okay.
What does this MRI shows?
There is a hypodensity on the right uh, posterior circulation, or more so in the cerebellar region, with perilesional edema.
No, you will not be able to. You will not able to. It's just a stroke in the post, basically in the right cerebellar area. Okay, it's a 2D
Yes.
image. It's a diffusion weighted image. Sorry. How will you approach and manage this patient?
Uh, First of all, I would go ahead with an ABC approach. His GCS is I think 7 or 8 on 15. Looking at his airway, if it is threatened, I would like to first secure his airway and put him on a invasive mechanical ventilation. Second, anyway, breathing is supported. With circulation, I would like to take a large bore IV cannula, send for basic investigations, including CBC to look for thrombocytopenia and rest of the basic things. And
You have to properly say.
okay,
List of patients, what are investigations you're going to send?
yes, complete hemogram with and a renal function test to look along with electrolytes to look for along with sodium and calcium and magnesium. And third is an ABG to look for hypoxemia, PCO2 levels, and lactate levels. And these are my and a coagulation profile. If and also ECG. These are the blood tests
You
that
keep on saying it.
Hypoglycemia.
If I'm not able to elicit, I'll give a prompt. Okay, what else you want to do it? What else you
Okay.
want to do in this patient?
Okay. Blood glucose, anyways, you have given. With the hyperglycemia, so ABG will give me an information about metabolic acidosis as well. And so yeah, so these are the blood and ECG that I would like to do.
Mm.
Mm,
Okay. Anything important you would like to do in this patient? What is this case?
Cerebral posterior circulation stroke.
Hmm. So, patient has come within 3 hours. You did an MRI, you did
Yes,
simulated imaging,
yes.
you noted that there is
So
a...
non-contrast CT.
No, you have done MRI. Why you want to do a CT now?
Okay, so we've already ruled out
Bleed, you already ruled out a
CT.
bleed.
Yeah,
Oh,
MR,
next, what you...
MR or CT angiogram. So
Okay, anything important you would like to do? A stroke which has come within, just your window is about to expire, 3 hours. There's a flare diffusion mismatch is there. What you would like to do?
I would like to go ahead with thrombolysis. So before
You,
that, we have done
no,
all
you,
the.
you see, in the meantime, you get the investigations done, but
Yes.
you will not wait for thrombolysis, right? You have to go ahead and do it.
Go ahead. Yes, sir. Yes, sir. But
Mm,
meanwhile, I would like to check his blood pressures
mm,
because we are considering thrombolysis. I would like to target the BP. I would like to have a BP of less than 185 by 110 millimeters of mercury.
okay.
And
Mm,
take an informed consent. And
mm,
also, I would like to dig further with the history from the attenders if the patient has any is on any anticoagulants or has any bleeding diathesis, or
mm,
has he undergone any major surgeries, or
mm,
has he had any strokes in the previous 3 months.
mm,
If no contraindications, then I would
mm.
like to go ahead with the IV thrombolysis.
Okay. Okay. Anything else you want to do other than this? You've done ECG, you've done a basic blood test, you've done coagulopathy, you
Mm.
secured the airway, then you're doing a thrombolysis also in the
Yes,
meantime.
yes, sir.
Anything else you would like to do it? You said it already. Again, I want you to.
I would.
Hmm.
I would inform a neurologist and a neurosurgeon, and inform ICU team as well for a post thrombolysis ICU care.
Okay, yeah, very good. Neurologist, you missed almost. Okay, neurology opinion you'd like to take. Then, what you do for your patients? You'll get an echocardiography also, right?
Yes, sir. Yes.
You'll
Echo,
get a CT angiography also, right?
CT angio, or MR angio. I
Yeah.
said it initially. Yes, sir. To look for any large vessel occlusion. So that's, and also the collaterals. I would like to do a CT angio or an MR angio,
Okay.
and shift the patient post thrombolysis to the ICU.
Okay. So you generally there'll be a list of answers they expect. Okay. Most of the time, any patient with coming with a stroke, you're supposed to say all these things.
Okay.
Okay. So what happens is this will carry marks, especially if you miss a thrombolysis or an
Mm.
option of thrombectomy for these kind of patients, they'll cut your marks definitely. Okay. In the meantime, one more investigation you will say is carotid and vertebral Doppler for this patient. If you have embolic infarct, especially, you're going to
Okay.
do a carotid or vertebral Doppler also.
Okay.
If they allow only 2 investigations to do in case of suspected stroke, which 2 investigations you would like to do?
One is non-contrast CT, and other one is to check GRBS.
Okay, very good. Okay, if this patient is eligible for thrombolysis,
Hmm.
how are you going to do thrombolysis? What is the dosage and which medication you would like to give?
So I would like to choose Altipace, 0.9 mg per kg body weight. So
Mm,
10% of it, I'll give it as a bolus in 10 minutes.
mm,
And the rest of it, I would like to run it as an infusion over an hour. Or
okay,
we could use tenecteplase as well.
okay.
0.25
is
mg
there any
body.
benefit of tenecteplase or alteplase or alteplase or tenecteplase?
Uh, Actually, it's the effect is same. It is non-superior. I mean, tenecteplase. However, there are the intraparenchymal hematoma in case of tenecteplase is found to be higher. So, I mean, the recent trials. So, I think we would like to go ahead with alteplase.
So why tenecteplase some centers prefer? Any reason, any particular case?
It is cost effective. Second, it is given as a bolus dose.
It is not cost effective, it is costly.
Oh,
It is
compared
more,
to
it is more fibrin specific. Okay. And if
okay,
there is a large vessel occlusion is there, it fares slightly better in case of large vessel occlusions. So tenecteplase is given in those cases. Okay.
okay.
Okay. This is about that. I'll not go into this. Okay. If patient is presented with wake-up stroke, how will you decide about thrombolysis?
So if a patient has come with wake-up stroke, the last scene is taken as the starting point. So I would like to do an MRI brain in him and look at a diffusion flare mismatch. If there is a diffusion flare mismatch, it is still within the window period of 4.5 hours. So I
Okay.
would like to go ahead with the thrombolysis.
Okay. So regarding, sorry, this side, if in case of I said a thrombectomy, no,
Yes, sir.
which patients I will choose, and what is the time window for thrombectomy?
Actually, it is if a patient has a large vessel occlusion, then they are the candidates for mechanical thrombectomy or endovascular procedures.
Mm.
So the window is for less than 6 hours, and we can extend it up to 24 hours as well.
Okay. Okay. Fine. Yeah, it was decided. I think you spoke about contraindication to thrombolysis already. I'll not go into that.
Okay.
This also we discussed. You thrombolyze the patient now. Now, how will you proceed in the further management?
I will shift the patient to the ICU.
Hmm.
And in the ICU, I'll continue him on invasive mechanical ventilation with the regular neuromonitoring. And
Hmm.
second, I'll give the instructions to the staff for no prick for 24 hours.
Hmm.
And I would like to maintain, to prevent a secondary brain injury, I would like to maintain normothermia, normoglycemia, normocarbia, and euvolemia. And we would like to mm, uh, repeat a CT brain post 24 hours after thrombolysis to initiate antiplatelets for the patient.
Okay.
And meanwhile, other supportive treatments like to initiate him on enteral nutrition
Hmm.
and reconcile all his older medications, I would like to do in the ICU.
So what you would like to do with the blood pressure?
Post thrombolysis for 24 hours, I would like to still maintain it at 180, less than or 180 to 180 by 110 millimeters of mercury. After 24 hours, we'll target the pressures between 140 to 160.
Okay. No, actually, you will not reduce pressure so fast also after 24 hours. You'll cut down gradually. You
15%
target
of
180 by 105. Okay. And you'll
okay,
cut down gradually. You're not going to go down so fast also in a cutting of generally 15% reduction.
15% in the
Okay.
first.
But in the some people say that you don't treat hypertension in a stroke patient unless it exceeds more than 195 by 180 by 105. Don't try to treat it also. There are evidences that it might be better to maintain BP on the higher side. Okay.
Okay.
Uh, yeah, that's it. You covered the most of the things. Then, what is the you said antiplatelet, single antiplatelet will give, right? Aspirin.
Yes,
So,
sir.
is there any indication for dual antiplatelets for any patients?
With an NIHS of less than 6 and not candidate for thrombolysis, then I would like to start him on dual antiplatelets.
Okay. And TIS.
Anti-yes,
NIS
yes,
is less than 5.
yes, yes.
Okay. Then what is the role for anticoagulants? Which patients do you start on anticoagulants? Hello?
Yes, sir, yes, I can hear you.
Which patients, usually we start few patients on Clexane, Doax, Noax and all, no? Which patients do you think will require these supports? Okay, basically in case of embolic strokes.
Embolic stroke, yes.
Okay, if you feel that there are multiple embolic, this thing is there, it might be AF or it might be from
Watershed areas. Okay.
carotid. So those kind of cases will be starting on Clexane or Noax or Doax in those kind of cases. Okay.
Yes, yes.
Okay. So this patient was shifted to the ICU after thrombolysis. You are managing with all these things. Patient had a drop in GCS to U1 VTM2. Okay, what is the next step in this patient management?
Since patient is already intubated, his airway is secured, I would like to further look for other causes of drop in GCS. I would like to check his blood sugar levels, rule out hypoglycemia. Second, because he's thrombolized, I would like to rule out hemorrhage, intracerebral hemorrhage in him. So, I would like to do a non-contrast CT brain. Third thing, also I would like to rule out non-convulsive status epilepticus, would like to do an EEG and also look for other metabolic encephalopathic causes, including dyselectrolytemia, especially sodium and calcium, sodium more so.
Anyway, I think sodium may not go down, but in the exam, for the sake of the exam, you might have to tell all those things. So in this patient, CT brain was done. It is showing this now. Can you tell me what is the finding here?
This entire posterior
Okay. Yeah, whatever you're telling is correct only. Please go ahead and say.
so there's a intracerebral bleed.
Bleed. You think it's a bleed? It's a CT scan. How does it bleed looks in a CT scan?
It looks white.
Hmm.
Yeah, but it's an established infarct.
Yes.
Yeah.
In fact, it's further about now
Involved.
involving both cerebellum,
Yes.
bilateral cerebellar hypodensities are noted.
Yes.
Okay. In the upper
Okay.
part, you are seeing this image.
So the CT brain is showing a diffuse cerebral edema with
You can't say edema. It's evolution of infarct per se.
evolution of
Hypodensities.
infarct.
Okay.
Yes.
Then what is this?
Evolu Evolution of infarct
No, the
established.
second CT image. What is that?
In the second CT only, there is a diffuse cerebral edema. I cannot make out sulci gyri. And
இல்ல இல்ல வேண்டாம் நான் இங்க பாத்துக்கிறேன் தாத்தா பாத்துக்கிறேன் இட்ஸ் ஓகே
You can appreciate hydrocephalus.
yes, sir.
Okay, that's a hydrocephalus.
Acute hydrocephalus.
Okay. So it's a bilateral cerebral stroke with hydrocephalus. Image finding is. How will you manage this patient now?
Because it is a posterior circulation stroke, so I would like to anyways now the neurosurgery team is involved. I would like to give a reference to them and a plan for decompressive craniectomy with for a acute hydrocephalus. I would like to do a EVD placement.
Okay.
And also, meanwhile, I would like to give a osmotic diuresis with either 3% saline or an mannitol, and keep him sedated, paralyzed, uh, uh, with an head and elevation to reduce the ICP.
Okay.
And the family for surgical decompressive craniectomy.
Okay. What surgery you would like to do in this patient?
Decompressive craniectomy, posterior decompressive craniectomy.
Okay. Then what else you would like to do?
With an
See, any
EV.
patient with ICP measurement, no, whatever you conveyed, no, you
Yes.
complete the entire list. What all things are there in that?
So I would like to sedate and paralyze, reassess his sedate and paralyze, give him a osmotic diuresis, give a neurosurgery review, yes, and decompressive craniectomy,
If
and
you put an
an external
EVD,
ventricular
you can
drainage
monitor the
procedure.
ICP also.
Yes,
Okay. So these things should come automatically for all cases,
okay, sir.
because invariably you have to mention, because it will be there in their chart. If you don't mention it, that marks will be cut in the exams. Example, if any patient has raised ICP, this should come as a if any patient has raised ICP, there you should, these things should automatically come, like head and elevation, avoid neck compression, normothermia, normoxia, normocapnia, ICP. If you are monitoring ICP, ICP keep less than 20, CPP more than 60 to 70, sedation, osmotherapy. This should come automatically.
Yes,
Example, ICP, you have to say these things. If ARDS comes, you have to have a set of answers. Invariably, ARDS will be coming in 1 or 2 cases in an EDIC exam. But every time a ARDS case comes or a raised ICP case comes, you should not think twice. If a ARDS case comes, you should say lung protective ventilation with high PEEP or moderate PEEP, limit plateau pressure, limit driving pressure, sedate paralyze, restrictive fluid. So all those things should come automatically in the exams. Okay, you should not wait. You should not think twice to say that what are the contents will come, because it's a neuro case. It is expected, or polytrauma case, whatever TBA case. These things invariably will come in your exam. Just make sure to by heart it. These things. Okay.
yes.
So neurosurgery team opinion was taken for this patient. Emergency decompressive craniectomy was done. Patient was continued on anti-edema and anti-protective measures. Just to finish the question answers per se, because I'm discussing the posterior circulation, you might get the same case with the anterior circulation also. What is malignant MCA infarct?
Uh, if the entire half of the cerebral hemisphere is involved, then it is called a malignant MCA tertiary infarct.
Okay.
And role
Any
of
other things you want to say, quantification perspective? Hmm? Okay. You don't basically if it's MCA territory, if it is more than 50%, or it's a whole territory, more than 2/3 of the territory is involved. Okay. Or if you are quantifying the volume in infarct volume more than 82 ml after 6 hours, within 6 hours, or infarct volume more than 145 ml within 14 hours. Okay. Maybe this infarct volume may they not ask, but MCA territory and the perfusion deficit you should remember for the exam. Okay.
yes.
So which patients will benefit from decompressive craniectomy in a malignant MCA stroke?
Actually, patients between 18 to 80 years are given an option. However, patients less than 60 years have fared better in the 2 trials that have come, Rescue ICP and the DECRA trial.
You're getting confused. You're confusing with TBA versus malignant MCA infarct. What are the trials with the malignant MCA infarct?
Rescue ICP and
No. That is for this thing. This is Hamlet, decimal, and destiny.
Hamlet and yes.
Okay. These patients had an overall very good outcome. But one limiting factor is if they've done it, if there's less than 60 years, they've done a Hamlet 2 study also, where they did more than 60 years outcomes. Even though their survival was there, they had a very poor neurological outcome in those patients.
Vegetative state was more. They were more of a vegetative state rather than good quality. Yes.
That is Hamlet 2, the study is. Just for finishing this case per se, what are the scoring systems which we use in stroke per se?
For hemorrhagic stroke, we have.
Any kind of stroke. What are the scoring systems are prognostic things you use it in stroke? What is pre-hospital? How will you assess pre-hospital?
NIHS.
That is in the emergency. Pre-hospital,
Um,
you can use it in the pre-hospital also. Something which is more
um,
commonly used by laymen also it is used.
Glasgow Coma Scale.
No more by laymen.
Or
Fast. Be fast. By emergency people, they use Cincinnati pre-hospital scoring system. Then
Link.
your NHS will come. Then aspect scoring will come. Okay,
Oh.
these are the few scoring system you should be aware in the exams. They might ask these questions. For outcome scoring per se, which are the scoring system you are aware of?
Modified Rankin.
Yes.
NHS.
Hmm?
Aspect score and modified
No,
rank.
no. For the outcome, one is the modified ranking. They use the Glasgow outcome scale and Barthel index. The scoring system is used for outcome scoring. Okay. Regarding NHS per se, do you think which patients will benefit most from thrombolysis with what NHS?
Score more than 6, less than 6, sorry.
Okay, range. You want to give any range? 5 to 15. Okay.
Oh, 5
Score between 5 to 15 are going to benefit most from thrombolysis.
Okay.
From the aspect score perspective, which patients will benefit with the thrombolysis and thrombectomy with what aspect score?
More than 6, sir.
More than 6 for?
Or aspect score.
No, for thrombolysis, what score? For thrombectomy, what score? Okay, for thrombolysis, it's more than 7. For thrombectomy, it's more than 6.
Okay.
Okay, so this we discussed already. This patient was shifted to the ICU. Patient, when you examine the patient, patient was noted to have absent bilateral pupillary and brainstem reflexes. In the meantime, MR-angio, they did it. In that, they noted that there is a left vertebral basilar artery dissection with occlusion. Okay. So how will you examine and what test you'll do for this patient? How will you approach this patient?
I would like to check all his brainstem reflexes.
Okay, can you list them?
Oculo,
You would have done at the bedside, right?
yes, sir. Pupillary light reflex,
Hmm.
corneal reflex, then oculovestibular reflex,
Hmm.
and his cough reflex,
Hmm.
and of course an apnea test.
Gag reflex,
Gag reflex, yes, sir.
cornea,
Corneal, I said.
Gaussian
Pupillary,
and
corneal, oculovestibular, gag, and cough reflex.
okay, fine. Then, okay, what other tests you would like to do other than this?
I would like to rule out rest of the before doing an apnea test. I would like to rule out rest of the any reversible causes.
Hmm.
Like I would like to check hypoglycemia, hyponatremia again, hypernatremia both,
Hmm.
and
Then,
his PCO2 level.
hmm.
And toxins or intoxication. But however, here we know the history. If there is an irreversible cause.
Okay.
So if everything is ruled out, then I would like to do a first apnea test.
Most important thing, medications.
Medications, yes.
Yeah, you have to wait for
Neuromuscular blocking agents.
how long you would like to wait?
For 2 half-lives.
No, 4 to 5 off-lives you have to wait. Okay.
Yes.
So, you told already. And how many people should examine it?
Independent of the treating physician, there should be 2 more physicians.
So what we are suspecting in this patient?
Brain death,
Okay. What are the ancillary tests you would like to do in this patient?
ancillary tests like transcranial Doppler,
Okay.
duplex.
You'll do it in all the patients?
Yes, sir.
Huh? Okay, go ahead. ECD, you'll do it in all the patients? How many patients have brain death you have done TCD?
Um,
When you're doubtful and you're not able to do some tests, then only you'll go for ancillary tests. Okay.
yes,
Okay,
yes.
tell me what other ancillary tests you know other than TCD?
4 vessel contrast angiography,
Okay.
CT or MRI angiography, EG, sir,
Okay.
and yeah.
Okay. So actually, there is a recent update from American Neurology Association. I don't know how much Europeans are taking that. In that recent update, they have removed EEG, they have removed AEP, they have removed SCP. Okay, there's no CT angiography, there's no MR angiography. You have to do a 4-vessel catheter angiography.
Yes, yes.
Okay, along with radionuclide perfusion scintigraphy. These are the 3 tests which are allowed. Okay. And
Yes.
brain death also they have used one more terminology for brain death. What is that? What is the DNC? I have mentioned in that. They use death by neurological criteria. Okay.
Okay, sir.
Okay. I'm not sure whether these things, whether Europeans are they put in the edic or not, but for practical purpose, you still you tell the EG, CP and all, or CT angiography. You can say that
Okay.
recently in American Neurology Association, they have removed it and they can convey that. Okay.
Okay,
But in the exam purpose, it's better to mention it and say that it is not used.
okay.
Can you tell me the procedure of apnea test?
Yes, sir. Patient is already intubated. So I would I'll adjust the ventilatory rate and tidal volume to achieve a normocapnia initially. And I'll pre-oxygenate him with 100% oxygen for at least 10 minutes to achieve a PaO2 of 200 millimeters. And if definitely patient should have an art line for an immediate blood pressure monitoring and also to draw an ABG.
Okay.
Next, to do the test, I would like to expose his chest to look for any chest movements during the procedure. I'll disconnect the endotracheal tube from the ventilator and connect him to nasal cannula tubing with 6 liters per minute oxygen. And I'll insert that tip into the ET tube towards until the tip of the ET tube. And I'll monitor the oxygen saturation. And also during the apnea test, I would like to monitor his blood pressures and support with pressors if needed. And after 10 minutes, and also look for any arrhythmias and any chest movements during the apnea testing. And after 8 to 10 minutes, I would like to do take the ABG and look for a PaCO2. It should have risen at least 60 millimeters of mercury or at least 20 millimeters above the baseline. Then the apnea test is concluded as positive.
How much oxygen you'd like to give?
6 liters per minute through
You
the.
just don't mention nasal cannula and all. You just
Okay.
put option catheter 6 liter per minute beyond the carina.
Beyond the can, yes, sir, tip of the attitude.
So if that numbers are satisfied, that's enough. Any update is there regarding apnea test? Any changes recently?
I would like to do a repeat apnea test 6 hours later after talking to
No,
the
that's fine.
family.
That's fine. What I'm asking is, in the procedure or interpretation per se, any changes recently?
Mm.
Okay, now they're using pH also. Previously, pH was not considered in the interpretation. Now they're asking for both change in pH and PCO2 both.
Okay, sir.
Okay,
Mm.
because if patient doesn't achieve this pH, it may not stimulate the breathing. So they've added pH also, and the previously R was there. Now they have put an and into that. Okay. Okay.
Okay.
Now, just for the finishing, this is from the edic perspective, communication is not an important thing. But from the exam or any clinical examination perspective, bedside practice per se, how will you communicate the family? Can you just imagine me as a relative of the patient? Can you communicate as a what are the things you're going to do?
Your voice is breaking, sir. Can you hear me? Voice is breaking, sir. Can you hear me?
Okay, now we have done all those tests. Can
Yes.
you hear me now?
Yeah.
Now we have done all those tests. Now
Mm.
you declared patient as brain death. Now you
Okay.
have to communicate with the family. How will you go ahead and communicate with the family? Imagine me as a patient relative and
Okay.
try to communicate me, maybe a patient brother or something.
Okay. So I would request you to come along with anybody else who is a part of the decision maker. I would invite you to the a room where we could sit and discuss on the patient condition. So now we are sitting in the room, and I've made you sit comfortably in front of me so that we can make an eye contact. You're at my eye level. I am. Initially, I would like to know what you know about the patient. Have you been regularly visiting the patient? If you know all the information related to the patient.
Okay.
Uh,
Doctor, they told me that my brother had a stroke. That's why they got him to the hospital. After that, they kept doing images again and again. Then they did a CT scan, MRI. So many tests they did, but they're not. They're telling that he's not improving, but they're not telling me properly what's happening with him.
Yes, sir. So actually, your brother came in with a stroke, and he had a stroke in a place which is very sensitive, in the sense that there is not much of a place where the brain can handle that pressure. So it was in that sensitive area. Still, he came in early to the hospital before the time he reached early, so we were able to give him a blood thinner, because of which that whatever block was there, we were able to tackle that. And but unfortunately, post that, it did not help him much. And immediately when he deteriorated, we took him for surgery as well. But despite trying all possible treatments available, he's not doing well. So currently it is deteriorated to an extent that there are these important centers in the brain which control our breathing, circulation, and rest of the important functions. So the stroke is evolved so much that all these areas are involved. So now he will not be able to breathe on his own, and his heart rate, his rest of the functions cannot happen on its, the brain cannot control that. So with this, at this point, I think we call it something known as brain dead, meaning his rest of the organs are functioning, but the main function which brain has to do, that is not happening. So with this, I think we have come to a point where we should discuss about what to do next. What is your take on how long you want to do this, or do you want to consider the next modality that we want to speak about? That's why I've called you to discuss. So do you understand what I'm saying? Do you have any questions that you want me to answer?
For completion purpose, I will not go too much into detail, but
Okay.
whatever you did was a monologue, okay?
Okay.
Always, when you're giving such a complicated information, he had multiple surgeries.
Okay.
Very important is giving a good pauses. When you give an information, give a pause and ask him whether they understood, or ask them to understand that condition. If you give so many information together, nobody is going to understand at the bedside, and it doesn't give a good impression in the exams also. Always pauses are very important. And one important thing you know, I'd like to communicate is at the end, sir, we did all those things. At the end, we don't have a good news, but we have a bad news, or something like that. You have to tell that and give a golden pass. They'll say,
Okay.
what do you mean? His
Mm.
his brain is not working. His brain dead, what we call it. That means his brain is not working well. The other organs are working. Okay,
Mm.
for all practical purpose, is no more.
Okay.
Okay. So
Mm.
when it comes to convey that important critical information that is brain dead, you need to have a lot of patience and you need to give a golden pass. You need to wait for them to understand and let them come back to you. Once you convey that information, you don't say anything extra.
Yes.
Just wait. Then they ask, what does it mean for us? Now, what do you mean? What we have to do if he's in that condition? Then you're
Okay.
going to communicate about organ transplant.
Yes.
Okay. So you have to wait when you give information. Wait. Always give information in bits and pieces. Ask them what do they understand.
Okay.
Which is the most famous communication tools which most of us use?
Spikes.
Yeah. Can you tell me the full form of spikes?
Uh,
Okay. I'll tell you.
sit-
Uh, okay. You want to?
Sitting.
Hmm?
Yes, sitting.
Not
And
sitting. Sitting.
understanding the
Hmm. Hmm.
perception.
Hmm.
And K is knowledge.
Hmm.
E is emotion. I is I is invite them for asking questions.
Yes. Yes. Is summarize.
Yeah.
Okay.
Yes. Yes. Yes.
Okay. You need to convey all this information.
Okay.
Okay. So next we need for family agreed for organ donation. How would you like to proceed? How would you like to manage this patient?
Uh, So I would inform the transplant team, transplant coordinator of the organization, and second, because there will be lots of hemodynamic fluctuations, I would like to support his hemodynamics with pressors and give him with injectable levothyroxine and
So basically, you are going to say that you are going to maintain lung protective ventilation. I'll maintain optimum PEEP. I'd like to maintain a target PAP of more than 60 to 65. These are normal things. Whatever you're going to do, you're going to convey that. One particular information you are going to do is if there's a DI, I'm going to do, we give azapressine or desmopressin.
yes.
Regarding this hormone replacement therapy, levothyroxine or steroids, you can mention, but that is found beneficial only in the context of cardiac transplant. Outside that, it doesn't have much role.
Okay.
Okay. So these are the things you should like to convey for from that scenario per se. So any electric disturbances, all those things you're going to correct. Okay. Just to finish it off, can you interpret the CT?
There is diffuse cerebral edema with
No, no, I'll not say diffuse cerebral edema, baby. It's just a image
no,
which is the one thing we are going to get highlighted there.
there is no flow.
What we are seeing here. This is the image which will be in the exam. This is a dense MCA sign, Soumya. Right, dense MCA sign is there.
MCFN, yes, sir.
It's one of the signs that my patient made a thrombectomy following a thrombolysis.
Yes.
Okay.
Okay.
Okay. This is about Alberta scoring system, aspect scoring system. I think you can read about it. Severe prophylaxis is not recommended. I think we discussed about this already. Dual antiplatelet in case of NHS less than 5 or TIA. In case of ICAD, if there's intracarotid or atherosclerotic disease, would like to give a DAPT. Actually, this is one more scenario where you would like to give DAPT.
Okay.
Okay. So I think we discussed this also, thrombolysis and thrombectomy. I think imaging duration, I think we discussed already. 0 to 6 hours, you're going to do MRI, diffusion weighted and flare imaging. Okay. If there is suspicion of this thing, we are going to do a CT angiography, especially in patient with high NIHS and suspicion of large vessel occlusion. Example, I showed imaging now where radiant sensation was there. Invariably, in those patients, we are going to do a CT angiography. Now there are trials are coming up. If patient comes even within 6 to 24 hours, that time you will going to do a CT perfusion and MRI perfusion imaging to see whether any areas which can
For
come.
the penumbra, yes.
Ischemic penumbra. Okay. Now thrombolysis, they're based up to 9 hours. They're extending based on the fiction trial, based on CT and MRI perfusion imaging. Okay. This one thing you would like to see. Okay, that's it. Any questions you have?
Mhm. Yes.
Any questions, anybody? Okay, I think we have covered more or less stroke related everything, including the some small aspect which might come in MCQs or in the practicals per se. I think this is going to be a standard set of questions for the stroke perspective. There are a lot of other conditions are there. Maybe neuro related SH is there. There is uh, status epilepticus is there. There is meningitis, encephalitis, abscess, the neuromuscular disorders. Any of these questions can come as one more case. Tomorrow, if possible, we'll try to do tomorrow. Next session, we'll try to do 2 cases because it is a long case. We didn't get much time. We'll see tomorrow, next session, how it goes. If possible, we'll try to cover 2 cases. Okay.
Yes.
Okay. Anybody has any questions? I think somebody has asked for recordings availability. We'll try to make the recording available. We'll try to put it on a YouTube so that you can see it later also. I don't know how much time it will take for us to finish it off. We'll try to do as early as possible. Okay. Thank you, everybody. We'll see you in the next session. You can give a feedback, whatever is there in the WhatsApp group also. We'll see and try to improvise upon the feedbacks. Thank you.
Okay, sir.